All right. Look at this fabulous panel of experts. We have to ask them some really tough questions. All right. So this one is going, oh, I should have brought my glasses. This one can go to one of our radiation oncologists. What is the percentage of patients who get recurrence that is radiation related who is 15 years out after HPV related head and neck cancer?
That's like a trivia question. So radiation is curative therapy for cancer anywhere in the body, and it is highly effective for HPV-related cancers in the head and neck, and also HPV-unrelated cancers in the head and neck. But there is a risk of secondary cancer. So radiation changes the DNA, and over time there is a very small percentage that you could form another malignancy in the area that you were treated. It is unlikely, in fact, that you would form a cancer elsewhere, but in that area, it could cause DNA damage later. The rates of that are extremely small, and they typically occur usually greater than 15, usually greater than 20 years later. The risks of that are really less than 5%, and probably less than that with modern techniques, but it is something that we have to think about. And another thing that we have to monitor for is not only your cancer coming back, but a secondary cancer in that area. Now, historically, head and neck cancers were more likely to be related to alcohol and tobacco overuse, which are irritants. And if you irritate those areas, you could irritate the area that became cancer, and you could irritate those neighboring areas as well. So it's more likely you would get a second cancer in the same area, but a separate cancer. In the past era with HPV, that's less common, but still by far and away the least common secondary cancer in that area is one that's related to your initial treatment. So not impossible, but very rare.
Excellent. Do we have any questions here in our live audience? Not yet. Okay. I have a question for Dr. Stubblefield. You mentioned this morning the lady with the dropped head syndrome was too late to get intervention. How late is too late? What's her journey back to get the appropriate care? So this is probably Dr. Stubblefield and Allison.
Yeah, thanks. I think this is on. Now it's on. There you go. So no, that lady in particular, there was sort of a lot of psychosocial issues that kept her from getting optimal care. So you're never too late to get treatment. We believe that treating things like dropped head syndrome early is likely to be more effective than when you start getting contractures and sort of fixed in this position. We have a lot of patients because the radiation, the way it's done, tends to sort of protract your shoulders, bring them forward, and then your head gets here, and these anterior neck structures start getting very tight. So it gets very difficult to normalize the patient's posture and range of motion later. So it's never too early to start working on neck range of motion. The truth is, in a perfect world, we'd be doing that prospectively before the patients even start treatment and making sure they have a program to do throughout it. And even if somebody comes in, we're not going to make them normal, but we usually can help with the posture. We do sometimes have to use cervical collars. That's a whole art in and of itself for patients who have sort of severe dropped head syndrome.
So a lot of it, I guess to emphasize that it's never too late to start physical therapy. Yes, we do a lot with the addressing the weakness in the cervical spine, the upper back, but we also have to look down the chain too. If a person is in a certain posture, we can't quite get them out of it, ideally. So we have to look at how the rest of the body is going to compensate. So, from head all the way down, we're looking at the patient. We're examining, lower body strength. We're looking at core strength. We're also looking at balance. So there's other areas that also need to be addressed that may not be directly, or I guess they are kind of directly related to the side effects of the cancer. But so again, it's never too late because there's other things that we can address.
Great. I'm just going to always scan you guys before I go on to the next internet question. So feel free to raise your hands if you have questions. All right. So this question comes in. Can you guys hear me? Is it going through? Okay, there we go. The question was, did I understand that radiation damages the DNA and the damages go on forever in my lifetime? Does this affect skin, bone? Is the damage restricted to the radiated field, or does it bleed out indefinitely into bystanding tissues?
I think I stuck the pin in that one initially, so I'll just say I think we both have different answers from the oncology point of view and from the neuromuscular point of view. The short answer is yes. Radiation damages all the tissues in the field, and it does it in this immortalized way, which is why the radiation late effects, can come on 20, 30, 40 years later, but more frequently, they'll come on in the first few years after.
Yeah, so Hello? The effect of radiation, the way it kills cancer cells is by affecting the DNA, and it affects the DNA in the areas that we treat. So in the head and neck, we treat the head and neck area, and as Dr. Stubblefield says, that is both what we intend to do in terms of the target and the tumor, but also the adjacent areas. Modern techniques that I think that Dr. Gensheimer spoke to you about this morning are much more limited in that. So it used to be 20, 30 years ago, pretty much everything side to side from your cheekbones to your collarbone got effectively the same dose without an interest in sparing things like the muscles, like the bone, like the neural structures, those kind of things. So we're doing a lot better, but still, we do have DNA damage. Now, your normal cells have a DNA repair mechanism in order to try to fix that. And that's one of the reasons we do radiation once a day, typically Monday through Friday for somewhere between 6 and 7 weeks, with weekends off to give your body a chance to heal those. But there is things and there are damages that the body doesn't keep up with. And so there are long-term effects of that, and they can be repaired and they can do well. But over time, especially without continued treatment of those areas with stretching and kind of reducing the ability for those areas to scar, that can be long-term. They don't leak out into other areas, so you don't have to worry about that damage kind of moving to other areas. But that's one of the reasons that we have so much interest in reducing the areas that we're radiating, protecting the normal tissues, and only treating to a dose that we need to control the cancer to try to minimize the long term of those effects. And it used to be the long-term rates of severe side effects like that were 30 to 40%, but now they're more in the 10 to 15% range, and we hope to make them even less than that.
Just wanted to add, which I think it is, one more thing to that is, while the radiation doesn't leach out, it's just confined to those tissues that are in the radiation field, any structure going through it can be affected. So there are a lot of nerves that go through that radiation field, so you can have hand weakness, for instance, or shoulder weakness, even if the shoulder wasn't directly in the radiation, as a result of the nerves that go to your shoulders being damaged by the radiation, if that makes sense.
Perfect. I'm going to take a little license. Dr. Orloff is in the center. Those of you who did not go to the thyroid cancer breakout might not know Dr. Orloff, but Dr. Orloff, I'm going to throw a question to you because Dr. Kahn presented some information about ultrasound devices. And I would love, as an ultrasound expert, to hear your thoughts on this concept of people ultrasounding themselves and sending you pictures from their smartphones.
Hello? Yes. Oh my gosh. That's, I am one of the world's biggest advocates of ultrasound. So I have a hard time not being enthusiastic about anything ultrasound related. Ultrasound is a technology that's been around forever, sonar and use in military purposes, and bats navigate by sonar. And it's a very clever way to use sound to produce images without any radiation exposure. So compared to other imaging technologies, it's safer and cheaper than just about anything else. But the image is, to some degree, only as good as the combination of the technology and the knowledge base of the person who's interpreting the image. So I think it's difficult to interpret ultrasound pictures without the context from which they're taken. And if you're using a device, it is helpful to know where on the body the ultrasound probe or transducer is being applied. So in that sense, doing your own ultrasound might be good because you know where on your body you're looking, but you kind of need to have the big picture, and that may be more difficult to do on yourself than on somebody in front of you that you're able to look at and and sort of move around freely. When you're navigating with your own arm, it's also going to be a little more difficult to, relax your neck muscles while also scanning and looking. It's just, I think I can't tell you how many people have come to me for treatment of their thyroid cancers who were physicians who were learning ultrasound, and they started by practicing ultrasound on themselves, and they said, oh my gosh, I've got a nodule. And then they go, like Prajakta said, and get the nodule formally ultrasounded and biopsied, and it turns out to be cancer. So it can be a good thing to discover things that need attention. I think there are a lot of thyroid nodules. In fact, more than 90% of thyroid nodules are benign. And so scanning oneself and finding nodules may be one of these things that creates more anxiety for most people than benefit. So I guess I'll stop with that and see if there are
Thank
any
you.
sequels to the question.
All right, I'm going to throw a question to Dr. Blemain. You talked really eloquently about advocacy, and I would love to hear what suggestions you might have for other folks who might be interested in being involved in advocacy or patient support groups, or what have you learned that you think might be helpful for other patients and caregivers?
Yeah, thank you. I think the hardest part for me was like figuring out what opportunities were out there. Like a lot of the things I mentioned today were things I kind of serendipitously discovered either through colleagues or friends. I think having an organic interest in something and then finding like-minded people. In my case, I guess being in the cancer world already, it was I guess a lot of that was like there for me. But like that's how I got kind of involved with that National Guidelines Committee. And then I think in terms of the THICA, where I was volunteering there, it was more, again, just that kind of organic interest and like something. I think I originally found THICA because of their cookbook for the iodine diet, which I know a lot of people that have done this, that's like the least fun part, probably the whole thing. Maybe the surgery might be worse, but just kidding. But yeah, no, I think, so anyway, I found it through a service that was offered, but that right there kind of is very telling to like kind of having that alignment of values of kind of patient-centered care. So yeah, I think the biggest thing is, identifying a specific area. I think in a lot of survivors, that area is the area that they have experienced, and that's where their experience is meaningful. Finding kind of communities in which there are like-minded people, and then those opportunities tend to kind of find themselves. And then there's also just the grassroots component of, like things like now social media is a platform for these types of things. And, if there's enough signal out there are people that are, wanting to push these causes forward. So yeah, just kind of, there's multiple ways to kind of find your own niche, but that's kind of how it's worked for me.
Fantastic, thank you. All right, Dr. Beadle, how typical is hair loss 1.5 years after radiation to the head and neck?
Hello. It depends a lot on, again, where the area was treated. Although typically there is hair loss at the time of radiation where the beams go through. So it's not uncommon for patients with sort of traditional and more common head and neck cancers to have an undercut and lose their hair back here, which then comes back with time. For those people who have already gone gray, it often comes back darker, which is a surprise. But it is unusual to have hair loss a year and a half later. So again, if it's general hair loss, I would look into kind of potential nutritional components or things like that. Make certain that you're still getting appropriate nutrition, how your weight is doing, things like that. And if not, I talk about it with your physician. Again, chemotherapy can also affect that. So if you're on additional medications later or for some other reason, I would see about that. It also can have thyroid function can also impact hair. And so I would make certain that your thyroid function is tested as well.
Perfect, thank you. All right, Dr. Khan, I'm going to throw this one at you. This kind of came up with Dr. Kalivas' talk, but since you went out there and mentioned the D-limonene trial that Dr. Lee is running, there was a question about when are we likely to know the results of that trial?
So trials go through different phases, and I think Dr. Lee's trial is still actively enrolling and determining feasibility more than successful applicability towards all of the patients that are out there today. So unfortunately, a lot of patients that come to our cancer clinic don't sign up for clinical trials. And so we're extraordinarily grateful for everyone who has ever signed up for a clinical trial. And the short answer is it's probably going to take at least many years before we find out things about D-limonene and whether that will reduce the side effects that we're dealing with. Now, whether that will be 3 years or 10 years, a lot of that is the uncertainty that comes with clinical research. And we're hopeful, but that's just one of the areas that Dr. Lee is looking at to reduce the toxicities of treatment.
Great, thank you. Jocelyn, can you talk a little bit about some of the voice issues that are associated with patients who've had thyroid cancer treatment and what kinds of options there might be for treatment for that?
Yes. So with a thyroid surgery, that can involve nerves that innervate the voice box, the vocal folds for moving. So if that becomes apparent during surgery, sometimes the tumor is involved or nearby, there's a concern that there's a weakness in that nerve. Or if it's something the patient reports as a persistent change in their vocal quality after the surgery, they'll be referred to us, and we can use a scope with a special light source, a stroboscopy light, to look at the vocal fold movement. And then from there, depending on what we see in terms of, there could be a little bit of swelling still, but in terms of the movement, we can try some different therapeutic techniques to see if we get a little better voicing and kind of assess, does this seem like there are some behavioral therapies that will help improve the vocal quality? Sometimes if it seems that there's more of a weakness, that there might need to be a medical intervention that could strengthen the voice, then talking with our other colleagues that are specialists in the larynx to help maximize the voice.
Great, thank you. Another question here from the internet. I'm curious if there's a standard or typical duration of how long the radiation takes for each treatment. Is about 60 seconds standard if using machine with special calibration, as in probably one of the slides that Dr. Gensheimer showed earlier?
It depends a lot on the technique and the extent of the treatment. So most places have appointments for daily radiation somewhere between 15 and 45 minutes, depending on the complexity of the case. But regardless, the majority of that is setting the patient up and verifying you're in the right spot. So again, all of us move around and we make the plastic mask in order to try to keep people in one place. But then we take pictures to verify we are in the right place, and that's by far and away the majority of that time. Most techniques have gone from slower delivery of radiation from fixed angles to quicker delivery from continuous angles. So now most treatments are really, the radiation itself is probably less than 5 minutes, and it might be closer to 2, but it depends a little on the complexity of the case and how it was planned, kind of where in that time it is. So most of it, again, is less than 5 minutes, even though the appointment is longer than that.
Great, thank you. Any other questions from our live audience? Are there any other questions online coming through? They're taking a peek. While we're looking to make sure we've answered all of the questions, I'm going to start with Jocelyn, and we're just going to go straight down the panel. I want each of you to say one thing that you think patients and their caregivers should think about or know, a word of wisdom, advice, whatever you want. I'm going to give you the open ability to say anything that you think will be helpful and meaningful.
Yeah, I get to start.
No pressure, sorry.
I guess what I would say is be picky about your recovery as things come along, and thinking more about like people earlier on, perhaps in that first year. Yes, there is this natural recovery of time, but like be picky about that neck that's stiff. Talk to people to really try to maximize function.
Yeah, and I would kind of have a corollary to that is, to really take advantage of multidisciplinary comprehensive cancer rehabilitative care, right? Even if it doesn't exist for you, you can sort of cobble it together from the resources in your community, and I think you'll do better as a result.
I guess I want to emphasize again that it's never too late to start physical therapy. It doesn't matter where you are in your cancer journey, whether it be right after your surgery, right after radiation, going through radiation, even weeks to months to even years after. There's always something that we can work on to help improve your quality of life. And also, when I see my patients, I ask them, "How are you doing?" And they start to tell me, and sometimes they can be very detailed, but then sometimes they'll say that, "Oh, I feel like I'm just complaining to you," but I'm asking you because we are screening for if there's something new that's come up. And I know we talked about this, and it was part of the presentation that we do want to kind of explain away what you're feeling. So it's always important to speak up. Even if you feel like you're complaining, make sure that you are being detailed as to what you're feeling, because again, it's about screening and listening to what you have to say.
Thanks. Well, I think I'd like to just emphasize what Prajakta, is that the patient experience, what you sort of mentioned about when you're told you have cancer, you want it out as fast as possible, and you might even go across the world to get it taken care of. And I do think that from the diagnosis to formulating the treatment plan, some of what's been said by others, saying it in a different way, yes, considering the multidisciplinary care available and a thoughtful approach to looking at the big picture before feeling that you have to rush to get the first treatment may be in your best interest, and avoid the need to do remedial treatment or remedial surgery, and especially in the context of papillary thyroid cancer, which is a cancer. Anybody who's told they have cancer feels that they want it gone, but that listening again has been said to the professional advice that the urgency of getting it treated may still leave room for a thoughtful evaluation, maybe even a second opinion, maybe additional imaging. Again, my passion being ultrasound, for example, doing thorough ultrasonography to get the complete picture before just acting upon it, impulsively with the first place you can get it treated. That would be my advice.
I just want all of you in the audience and on the live stream as well to be aware that no matter how much suffering you guys have gone through, you should be aware of the positive impact that you've had on us as your doctors. Because when we see your strength, when we see you guys coming in with your head up, smiling, laughing in the face of so much adversity, it's personally made me, a better son, father, husband, and general human being. And I'm just amazed at all of you. And I just want to thank you guys for all that you do so that we can be better people in our own lives. And I wish there was a better way for us to do that rather than see you go through such difficult things, but it is truly inspiring.
I'd just like to share a perspective. I think it's pretty common when patients are first diagnosed or going through treatment that there's this tendency to want to get it in the rear view. And I think we get asked as clinicians a lot, when will I be done with treatment? When will I be done with this? And I think what patients find, at least this is how it's been for me and my experience treating patients too, is they've come to find that for better or for worse, this is a lifelong process from the date of diagnosis. And so while there is some kind of grief to that, I think there's also a lot of power in that as we kind of celebrate survivorship. But it is kind of an identity framing experience to a large extent. And we've seen that play out in these talks in a number of ways, whether it's scan anxiety afterwards or kind of celebrating milestones, all these things that as we go forward, I think kind of having that perspective of kind of this is a lifelong process that we should celebrate both as survivors and as clinicians taking care of you. That's what I would give advice to kind of foster that perspective among patients and as they get diagnosed and progress through.
Thank you. I think my comment would be that we're partners and this is a team sport, and it's not just your physician, but it's also your speech therapist and your physical therapist and your dentist and your surgeon, and most importantly, your family. And I think everyone tries to be strong for each other, but I think we all have take turns kind of carrying the burden at different times. And the best thing to do is kind of lean into your support and continue to communicate and know that this is going to be really a long-term relationship, and it's a marathon, even in survivorship and even with good news, and that we all have to depend on each other to move forward. And we look forward to more good news. And if there's ever bad news, we're going to deal with it together.
Thank you. I'd love to stop on that, but we did have 2 more questions that came in. So, Dr. Khan, for metastatic thyroid cancer with an inoperable 2-centimeter tumor in the brachial plexus, when would TKI be used if lung mets are stable? Very specific question.
So I think to answer that, right? So with very specific things like cancer that has come back, specifically thyroid cancer, the use of these amazing new targeted therapies that are so spectacular in the treatment of previously refractory thyroid cancer, the timing is the hardest part, because often there is a desire, as Dr. Orloff mentioned, that people want treatment now, but studies have been done that shown that starting treatment with these very potentially toxic drugs later versus earlier results in the same survival. And so that's where making sure that you have the full confidence in your doctor, that when they say, you don't need to start treatment today and I'm going to keep a close eye on it and it's okay, that is the most important thing. So there isn't a right answer. In some cases, I might start immediately. In some cases, I've had patients wait 5 years before they start tyrosine kinase inhibitors.
Perfect. All right, one last question. What's the difference between SPONC, so for those of you who don't know what that is, that's support for people with oral head and neck cancer, and the Head and Neck Cancer Alliance? If nobody else wants to answer it, I'm happy to. Okay, so SPONC is basically a support group and a network of support groups. So SPONC is oftentimes patient-led support groups. We have a chapter of SPONC at Stanford that meets currently virtually, but also in the past in person. So the primary focus of SPONC is support for patients and caregivers. The Head and Neck Cancer Alliance goes a little bit further in terms of also doing advocacy, patient education. We partner very closely with the American Head and Neck Cancer Society. So that's sort of the professional organization, particularly for the surgical subspecialties. So the American Head and Neck Society and the Head and Neck Cancer Alliance do a lot of work together to advocate for patients and caregivers, to provide education, to fund trials, those sorts of things. So SPONC is a little bit more of a patient support group, and Head and Neck Cancer Alliance is a little bit more of a broad advocacy organization. All right, any last burning questions? For our virtual folks, it's much more helpful to use a microphone. Thank you for waiting, Larry.
This is awesome. Thank you very much. So my question was really related to therapy, and I'll try and end it on a humorous note as well. So for me, one of the big challenges of therapy was just doing the exercises. So as an example, when I heard the statement earlier, oh, just do it 3 times a day. And I'm like, what the heck? And, for me, it was like, oh man, I'm lucky if I can do it every other day, or, in terms of a mental base, even though I have plenty of time to do the exercises. So my running gag with Heather was actually for some of the swallowing exercises or jaw opening exercises. I would send her pictures of the, let's call it Blondie Dagwood Bumstead type sandwiches I was eating, which, are, like that. So I was wondering if any of the folks involved in therapy are doing anything, let's say, out of the box or cutting edge or anything else to try and make this, a more engageable type of activity once people leave the therapist's office.
There is So I've done something similar where kind of like an accountability thing where I've had a patient, okay, do this and text me the sheet that shows me that you did these exercises. I think it's a little different for each person in terms of what helps to support them and motivate them. For some people that might cause them to not do their exercises and be overwhelming. A couple of things come to mind, and you could speak more about the trial that is kind of wrapping up. But one of the things that we have is a biofeedback device that we're doing with some patients where it gives you feedback. It's a software and it's a sensor that you wear just underneath your chin, and it doesn't just give you feedback in terms of like repetitions completed for some exercises. It gives you feedback in terms of how hard you swallowed by way of how much electrical activity is generated during the swallow. So it's not something that we have a few devices that we're doing with some patients that are ongoing, undergoing ongoing swallowing therapy. And then we can spy on you. We can see when you've logged in, how many repetitions, and if you've met your targets. So that's definitely I think it's being used more and more. I'm seeing more institutions that are using this particular device. This device is actually, you can obtain it yourself. It doesn't need to be prescribed by us. You can go ahead and you can buy the device and the software for it. And I'm blanking on its name right now.
The Mobility.
Yes, the Mobility. Is the name of the device that's seems to be the most prominent on the market at this time.
Go ahead, Beth.
I was just going to say that sometimes I think the opposite of good is better. And if we ask you to do 1,000 things, the answer is probably 0. And if we ask you to do 10, you might do 10. So it's to try to figure out kind of what a reasonable thing is that fits into your life. And again, more in a lot of cases is better, but more shouldn't preclude any. And trying to fit it into your life. And so, the other thing is oftentimes after radiation, we recommend dental trays. And, some dentists will say they have to be in your mouth with fluoride in them for an hour a day. That's a long time to be drooling and not doing anything else. And my answer to that is put them in the shower, put them in while you're in the shower. Every time you shower, is it an hour? I don't know. It depends on your shower. But it's more than 0, right? And so if you can come up with an exercise plan where you could do them in the car, or if you're watching the game at the commercials or something like that, it's more than nothing. And sometimes I think anything is better than not. And when we ask you to do too much, and that's where, again, the communication comes in. I can tell you the best thing for your cancer is to do cartwheels on the moon. It's not going to happen. It's not going to fit into your lifestyle, and it's not practical. And I think being really practical is really important.
Yeah, very good points. And I think one of the things that Jocelyn was deferring to me to talk about was we just completed a multi-center clinical trial looking at using a mobile app during radiation. So the focus of it was for during radiation to support people with their exercises by giving them videos and reminders and those sorts of things. So that's something that we've worked on specifically for the getting through the tough time of radiation. And some of you in the room have used this, and some people were superstars with it. I won't point them out, but they can out themselves if they'd like to. But I think that what you're alluding to perhaps is also that period of survivorship after radiation, and how do you kind of keep that maintenance steam? And I think it comes back to what Dr. Beadle says, is that we might give you a list of, we think this is the best thing. Number one, the truth is we don't know that. So we know that keeping things moving and keeping things strong tend to be protective, but we don't know what the right dose is. So the right dose is what you can do and what's reasonable and realistic. And the sandwiches that you're eating are probably the best exercise I've ever seen anybody do after head and neck treatment. So there are some swallowing therapies specifically that target sort of eating and working around foods that are enjoyable for people. So integrating exercise into enjoyable activities. So there's some emerging evidence on that as well. Yeah. And without further ado, thank you all and have a wonderful rest of your weekend.